Good morning, my name is Nicole Fabien. I'm a biologist specialized in autoimmune disease, and I'm working in the immunological department in Hospice Civil of Lyon. So first of all, I will speak today on the strategy and diagnosis of autoantibodies, but as this is a huge domain, I will just focus my talk on the major disease studied by the Filière network, such as systemic lupus, juvenile idiopathic arthritis, Sjogren syndrome, systemic scleroderma, myositis, and vasculitis. So in our strategy in the lab, we choose to screen by indirect immunofluorescence technique two types of antibodies: for systemic disease, anti-nuclear antibodies, and for vasculitis, ANCA. And then after this screening, we have to identify the target antigen using different techniques to improve the diagnosis and prognosis of autoimmune disease. So I will give you some pitfalls of the techniques, whatever the presence of autoantibodies and sometimes the absence of them. And I will just want to reinforce also the discussion between clinician and biologist to improve the interpretation of the autoantibodies. So first of all, anti-nuclear antibodies. This is a really good test because it demonstrates a great performance. As a negative test, in fact, is very rare in systemic diseases, especially in systemic lupus. So we see that there is a poor specificity because you've got ANA in some other disease or like viral or bacterial infections, drugs, and healthy people older than 60 years. But this specificity is better when you identify the target antigens, whatever in the nuclear antigens. Here you can see that by indirect immunofluorescence we can have some speckled pattern, homogeneous pattern, nucleolar pattern, and cytoplasmic ones, and we can decide in fact to identify some antigens when you have this special pattern. We use some technique other than indirect immunofluorescence, ELISA, DOT, but here you are aware and cautious of the technique used because the antigens used in technique have been purified or recombinant, or sometimes conjugates are different and can give false positive and sometimes false negative reaction. First of all, for the systemic lupus, you know all that ANA belong to the immunological criteria for this disease, and it is very important. There are many autoantibodies described in systemic lupus, but I will focus on the interesting antibodies, such as anti-SM antibodies, which the prevalence is not so high, only 10%, but the specificity is really high, about 95%. Then you've got the anti-SSA antibody, but only the 60 kDa, and which are present in different phenotype of lupus, but also in Sjogren syndrome. Here are two pitfalls. With some HEP2 cells, you know, we have some false negative. So when you ask for anti-SSA, be sure that the laboratory make an identification technique, because you can have false negative. And the second pitfall is that sometimes when the lab use a mixture of anti-SSA 60 kDa and anti-52 kDa, it could be a result of positive anti-SSA, but only 52. So be aware that there are no interest for antibodies against 52 kDa. For anti-U1 RNP, 60 kDa, they are very important with a prevalence of 30%, but they are also present in Sharp syndrome. One antibody which is also very interesting is anti-Chiao antibodies with a prevalence of 5 to 10% and present also in myositis. But it could be interesting in lupus with no particular other antibodies. Two pitfalls in this diagnosis is anti-PCNA antibody. We thought that they are very important with a good specificity, and but we made a study, a multi-center study, which demonstrated that anti-PCNA antibodies could be detected in other diseases than lupus. So you have to not interpret them as a specific marker for this systemic lupus. And the other also pitfalls here is the presence of anti-dense fine speckle lens epithelium-derived growth factor, anti-DFS 70 key antibodies, because they can mask anti-dsDNA or anti-SS antibodies. And of course, they have been discovered and detected in healthy people, but you should be aware that they can mask anti-dsDNA and anti-SSA or antibodies which can be useful in systemic lupus. For anti-dsDNA antibodies, very specific normally for lupus, but once again, be careful of the technique that be used to detect them, because you see here, we thought that Faraday is the best technique, but nowadays it's quite difficult to perform them in routine lab. And so we have to use ELISA or other immunoassay that could be can give a poor performance in terms of specificity. You see that some ELISA give 19% of specificity. That's not very good, you know. You can have also false positive, but normally always IgM in Gaucher-Chagrin syndrome, autoimmune hepatitis, and with some drugs, anti-TNF alpha. And at last, their absence do not exclude the SLE diagnosis, of course. When I talk about the value of identify ANA, that's a cartoon slide where we can see that in some infection, cancer, or drugs, you can have a very high amount of ANA, of positive ANA. Even in blood donor and healthy people, patients over than 60 years, you see 20% of patients could be positive. And what I recommend is a higher deletion of the screening of ANA, because you see that only 5% can be positive against 13% using a low dilution at 8.80. So you know that there are a lot of different autoantibodies described in systemic lupus, more than 150. But among this huge amount of autoantibodies, some are really interesting also, like anti-nucleosome antibodies present in lupus without dsDNA. That so you can ask for them if you do not have any positive marker for lupus. The second one is anti-ribosomal P proteins autoantibodies, which give a really typical pattern on the cytoplasm of F2 cells, and they are very, very specific of lupus. The third one is anti-CNQ antibodies with a really interest in the activity and renal flare both in pediatric and adult patients. For the other one, anti-histone antibody, forget them because they are no more interesting. They give a poor specificity, and so don't ask anymore for those antibodies. One antibody that could be interesting is that anti-interferon alpha-2 autoantibodies, as we can detect them nowadays with a commercial kit, and we try to understand what is the role of these antibodies in autoimmune disease and also their prevalence. For the antiphospholipid autoantibodies syndrome, that is our frequent marker in systemic lupus, you can have two types of markers, one conventional markers, and you should ask for three of them: lupus, anticoagulant, anticardiolipid, IgG and IgM, and anti-beta 2 glycoprotein 1, and you have to ask for two tests within 12 weeks of interval and with high titers, because you can have often low titers and in infection disease, in viral infection notably. So you have to be sure that in 12 weeks of interval you keep these high titers to be sure that it is a good marker of antiphospholipid syndrome or in systemic lupus. We've got also non-conventional markers such as isotype IgA and also antiphosphatidylantanolamine, antiprothrombin, which are very interesting in some case of CAPS with no conventional markers. For the other disease which interests the FAIR network is juvenile idiopathic arthritis. ALNA are often asked in first intention, even if there is no really diagnosis utility because they are not very specific, but their presence is really associated with an increased risk of uveitis. In this disease, you can also detect a rheumatoid factor, even if they are rare. Their presence also is associated with a severe prognosis. And you can also detect anticyclic citrullinated peptides. Another disease is Gougerot syndrome, Gougerot-Sjogren syndrome, with the presence of anti-SSA of 60 kD8 present to 60 to 70% of patients, but sometimes they are not present and you can detect ANA but with no specificity. And sometimes also rheumatoid factor, and sometimes no autoantibodies at all. There is also a great interest to detect autoantibodies in this systemic sclerosis because you see that nowadays the presence of one of these autoantibodies, such as anticentromere, anti-topoisomerase 1, or anti-RNA polymerase 3, give 3 points in the score, and you know that you have a total score up to 9 to be classified as having a definite systemic sclerosis. So which autoantibodies to be chosen to this systemic sclerosis? Besides the antibodies with a physiopathological role, such as anti-endothelial cells, anti-fibroblasts, and anti-PGF receptor, we show here that you have a huge amount of other antibodies which could be very useful in the diagnosis and prognosis of this disease. You see here that 3 antibodies such as anticentromere, anti-THTO, anti-PMSL are associated with quite good prognosis in this disease. But when you have the presence of anti-SL70, antifibrillary, and anti-RNA polymerase 3, it is really associated with a poor prognosis, a severe prognosis. So for anticentromere antibodies, which are present in limited systemic sclerosis, up to 40%, you should have the typical pattern to interpret the positivity of these antibodies. For anti-THTO, they are not really prevalent, but could be interesting because they can be a predictive value for a scleroderma. And once again, be careful because some dots give a false negative ET of these autoantibodies. For anti-PMSL antibodies, they are present in patients with both disease, scleroderma and myositis, with a moderate severity, and they give a typical pattern on speckled and nucleolar pattern, which is very characteristic of those autoantibodies. We speak now of antibodies which are more associated with severe prognosis, such as antitopoisomerase 1 antibodies, present more in diffuse sclerosis with a prevalence of 50% in adults and 34% in children. And once again, like anti-centromere antibodies, you should have a typical IF pattern because some identification technique give false positive, but really with sometimes low level. Antifibrillary are antibodies against with a poor prognosis, with renal crisis, calcinosis, and myositis. And they are quite typical by IF. So you should ask the biologist when you have this typical pattern to identify them as antifibrillary antibody with some dot. For anti-RNA polymerase 3, again, poor prognosis with renal crisis and cancer also. You see that in our cohort, we found that 27% of patients with these antibodies display a cancer. So be aware and ask for searching a cancer when you've got these antibodies positive. For the big group of myositis, it's really interesting to see how numerous antibodies, new antibodies have been discovered and could be very interesting in diagnosis and also in prognosis because anti-MDR5 are associated with extremely severe pulmonary manifestation, anti-NXP2 and anti-TIF1 gamma with cancer, so they are very, very interesting in clinical practice. For immune-mediated necrotizing myopathy, you've got two antibodies, anti-SRP and anti-HMG-CR. And for myositis overlap syndromes, I will just discuss on the anti-synthetase syndrome. And the last one, for the inclusion body myositis, you've got the anti-CN1 antibody. For the anti-amino acid RNA synthetase, we demonstrate that 11 can be detected, but the major ones are anti-G1, anti-PL12, and PL7, as the other give a poor sensitivity because of the techniques. We don't have a really performant technique to detect them. For anti-G1, just to know that we can have false negative using IF, so you have to ask them, namely when you have a suspicion of myositis. For anti-PL7 or anti-PL12, we don't have any much problem because they give a typical pattern in on HEP2 cells, a very nice cytoplasmic pattern, and it could be useful, these antibodies, also in some ILD with no myositis at all at the time we discover this antibody, but what on the predictive value, it could be very interesting. For anti-MDR5, which are present in clinical amyopathic dermatomyositis, we know that it's extremely important to detect them because they are often associated with a rapid, progressive, and severe interstitial lung disease with ischemic ulcer, very typical, and sometimes with viral infection also. We've got some pitfalls like other antibodies because we've got some false negative with some dot. For anti-TIF1 gamma, which are also very, very important because they are associated with cancer, and you see here that in our cohort from Lyon, 88% of patients with these antibodies have a cancer associated or develop a cancer within 2 years before the discovery of these antibodies. Again, anti-NXP2, P2, interesting in juvenile dermatomyositis and adult dermatomyositis with, again, an association with cancer. For immune-mediated necrotizing myopathy, anti-HMG coenzyme reductase are very important, and they are very good technique. Whatever you use for this antibody, we are lucky because the prevalence is up to 25% and the specificity is really high, about 99%. And again, they are associated with carcinoma. For anti-SRP antibodies, it's not the same because you should have a typical pattern on AP2 cells to really show that the antibodies are positive, because some dots give false positive. Sometimes they are low level, but sometimes high level. Anyway, you should have both typical pattern and identification with some dot. The last one is anti-CN1A autoantibodies in patients with this disease with a typical clinical feature with slow progressive muscle weakness. And we've got quite a high sensitivity in our cohort of more than 70% and with a really good specificity of 88% compared with some dermatomyositis. And at last, I will speak on the ANCA, because you know that ANCA nowadays are associated with ANCA-associated vasculitis. And like ENA, we perform a screening using RF, and when the positive RF is here, we have to identify them with anti-myeloperoxidase kit or anti-proteinase 3 kit, and thus they are really important. Once again, we've got some pitfalls because they are false positive, certainly due to the major presence of ENA. And you should also be aware that the presence of anti-PR3 or MPO are present in non-vasculitis disease such as ulcerative colitis or viral infection. And last, we can have some false negative, around 1 to 5%. That could be anti-MPO or PR3 positive. So when you have a real suspicion of vasculitis, please ask both antibodies with IF. So thank you for your attention, and there is my mail address if you are to ask me some more questions on these autoantibodies and techniques and whatever you like. Thank you.